Welcome to Inside Aesthetics, the world's leading podcast for injectors and aesthetic businesses. I'm Dr. Jake Sloan, an aesthetic doctor with over 16 years experience in facial aesthetics.
And I'm David Siegel, an entrepreneur and business mentor with over 20 years of experience in our industry. Our podcasts are aimed at industry professionals, and any information or advice given is general in nature. You should consult with a healthcare provider before undergoing any treatment.
You can also subscribe to us on Patreon for on-demand content for injectable and business education.
Hey guys, before we jump into today's 300th episode, a little bit of information from Jake and I around the structuring of this, because it was such a long discussion with both Gene and Michael that after 2.5 hours, we thought we've got to split this into 2 episodes.
Yes, so part 1 is about the history of toxins and aesthetics, and then part 2 will be about the present day and the future of aesthetics. Now, part 2 will be available through our Patreon. Now, it's free. All you need to do is subscribe as a free member. The information on how to do that is down below. It will take you about 1 minute to do. And we look forward to seeing you potentially somewhere else in the future. So what other news do we have to give to everyone?
Well, in true IA fashion, we love a competition, and no better time than where we've done 300 episodes together. So for further details on how to join this amazing competition, check our Instagram tonight. All of the instructions will be there for you. And without letting the cat out of the bag, I can give you 2 hints. The first one is that you may want to pack your bag, and the second is that you may run into Jake and I at another location around the world.
Very exciting. So just as a reminder, our Instagram is Inside Aesthetics Podcast. Check it out tonight. You'll see our reel, and good luck to the lucky winner. We made it to 300. I can't quite believe it, but here we are.
300 episodes, and how many years? 6.5 years?
Yeah, about 6.5 years. I've got some statistics to throw at you.
Go on.
We're recording technically this episode 298, but this will be episode 300. Right. We've still got 2 more to record, but we've had 2.21 million downloads or streams in that time. So quite impressive. We've had 13,608 people hit the subscribe button on Apple or Spotify. So those are our, if you like, our fans.
Yes.
35,000 unique listeners to at least one podcast. So you're doing all right?
Yes.
You're not too boring.
Look out, Joe Rogan. Yeah.
Yes. And apart from these countries, Mauritania, Niger, Central African Republic, Somalia, Angola, Chad, and Turkmenistan, we've been listened to every country in the world.
That's really good.
It's quite impressive, isn't it? So we need to improve our marketing in Turkmenistan.
We've done well. That's been great. Gosh, who would have thought that when you walked into my clinic and when I bought that business back in whenever it was,
2016, 17.
Yeah, that we'd be here 6.5 years later. It's wild.
Absolutely crazy.
So thanks for putting up with me. I know I'm a pain in the butt.
I can assure you that the sentiment probably goes both ways. But no, seriously, I've appreciated all the hard work that you've put in.
Oh, you too, my friend.
Thank you very much. Now,
and thanks to our listeners, and our Patreon subscribers, all the people that make it possible for us to continue on, because it is a big job.
Absolutely. And hopefully this episode whets everyone's appetite. So I've been very excited about this one. We welcome back 2 absolute juggernauts, pioneers, rock stars, whatever you want to call them. We have hosted Dr. Gene Caruthers and Michael Kane before, so we've already been blessed by their presence. If you haven't listened to those episodes, they will be a good prelude to what we're going to be talking about. So we first hosted Gene back in episode 120, and Michael was episode 190. Now, if you are a new injector, maybe the history passed you by and maybe you've not come across their work, but they really are pioneers in what we do, especially with toxins. So listen to those episodes first, because we're not really going to cover that ground again. Their story, how they discovered Botox and how they started playing with that. That's all covered in the previous episodes. And when we put out a call for listener questions for this episode, so many people asked questions that are already answered. So sorry if you felt like you wasted your time, but you will get the answers if you listen to those old episodes. But anything to say to our guests before we crack in?
No, just thank you. It's been a challenge coordinating different time zones. And I know you're respectively each super busy with families and your own busy practices and traveling the world teaching. So thank you for making the time. And I'm really excited to talk about today's topic, which, as you said, Jake, we've broken it up into 3 distinct sections. So we're going to be talking about the state of aesthetics as it is today, what it was like in the past, and then also looking forward into the future. So that's 3 segments.
Yeah. Also, I guess the other reason to get Michael and Gene on, their episodes are comfortably in the top 5 of our most listened to or downloaded podcasts. So it made sense to get the rock stars back to celebrate our 300th episode. So let's kick off. I want to ask a question. This is quite a nerdy question. I don't know whether I ask it to Gene or Michael. You can both jump in. But I've never been supplied with a satisfactory answer to this question. I've always been taught, when I've learned about toxins, especially the more traditional toxins like Botox, Dysport, that it comes from something called the Hall strain. Now, to my understanding, Ivan Hall was a microbiologist messing around with Clostridium botulinum in the 1900s, and he found some samples, gave them to, I don't know, educational institutions and said, play with this stuff. And he gave them different subtypes. And so from all of the toxins that have come about in the last, 25 years, presumably they've had different subtypes already as their, if you like, their starter yeast, if you like, that whole strain. So what is a Hall strain, I guess, is my question, my long rambling question. I'll start with Michael and then Jean can add in anything else.
It's exactly what you said. It was the initial subtype that I think that Hall probably sent to Ed Shantz. And I think all the initial 4 toxins were all A sub 2. Interestingly enough, as we get into toxins 5, 6, 7, 8, 9, 10, the ones that are coming to the States, they've stopped declaring what subtype of Hall A they are. So I'm not sure. I'm not sure if it really matters. If you, without giving away any corporate secrets, all this starts with a bacteria, and it's the Hall subtype A. And what is the IP of each company and what makes each product different are the steps that you take to get from that bacterium to the purified protein that we inject.
Yeah.
The bacterium is not IP, and it's the steps that each company takes. They closely guard all their steps, which determines the final formulation, which is why all the products are somewhat similar, but not quite identical, because the formulations and steps aren't identical.
Yeah. Jean, do you have anything to add to that?
Well, it's analogous, I think, to something everybody knows about, which is Coca-Cola. The recipe for Coca-Cola is their IP. And so the recipe for all these different neuromodulators is how they are made. And so there have been lawsuits alleging that your toxin was taken from our lab. And that sort of, the recipe is surprisingly similar, that sort of thing. But there is a new neuromodulator that is going to be produced will be approved by one of the neuromodulator companies that is a completely new strain of Clostridium botulinum. So we've maybe been A'd out. And now we're going to have another strain totally. So it'll be, I can't tell you because it's not approved yet, but it is something to watch for.
Yeah.
Okay. So we should still generically call them the Hall strain. They are almost the same, regardless of the brand.
In Canada, we'd say they're all A.
Yes. Okay.
Very good. Very good. Michael, is it correct that this was discovered obviously by accident and they were using this type of technology as a bioweapon? Is that kind of how it started? Why are we messing around with this stuff?
It started a very long time ago, but it was first recognized, I think, with some bad sausages. And I think Kerner was the first person to describe what was going on. And what we knew was that it was incredibly toxic. And of course, that was type A, which is in the natural world the most toxic because it is the most potent. So of course, naturally, that's the one we use. That's the one that all the formulations are of until, as Jean just mentioned, somewhere in the future, there may be a non-A.
Yeah. Jean, you mentioned in your podcast with us a while ago that your mentor, Alan Scott, started playing around with this stuff for strabismus and I think injected monkeys in his trial. So where did he get the stuff from? Because this wasn't developed as a drug until he developed it into something called Botulinum. So where did he get it from? And how did he do it safely? How did he get it into the lab and not cause an outbreak?
Yeah, well, he got it from Ed Shantz.
Right.
And the reason he got it from Ed Shantz was that he'd had a conversation with another ophthalmologist, Ed Momini, about maybe you could use a drug rather than surgery to straighten misaligned eyes.
Yeah.
So Ed Shantz had been working at Fort Detrick in Maryland and then moved to Madison, Wisconsin. And so it was from Madison that Ed would pack up the vials of botulinum toxin A and sent them surface mail in a brown paper packet to Alan Scott. And this is the real thing. When nobody knows about it, this is like stealth mailing or stealth delivery. Nowadays, there's a jet with guards and one thing and another. But that was in the simple times when nobody knew what this was.
That's pretty incredible.
Sending dangerous stuff in the mail. It's like Unabomber stuff. Like,
is it really dangerous? You would have the LD50 as being calculated for the average 70 kilogram human. And it's something like 1,500, Michael, or 1,800 units. And if each vial units, you'd be broke before you're dead.
Yeah. I guess I wondered if they had any concept of how many units you need. It's not like they're sending a 50-unit vial or a 100-unit vial like we have now. Maybe there was gallons in there because you only need 5 nanograms, I think it is, in each 100-unit vial. So maybe they didn't fully understand that concept, putting it in the brown paper bag. I don't know.
Oh, no, I think they understood it because it was not the carboy that was shipped. It was not the anaerobic carboy. It was vials.
Okay.
And they were vials with green labels with 200 units in them, I think.
There you go. So it got sold to Allergan for about $9 million in 1987. So did you have any discussions with Dr. Scott around what you were doing with cosmetic purposes? Because it feels like there was an opportunity that kind of passed us by or passed you by, really, in this sort of getting done and that being sold to Allergan.
Allergan patented it as the recipe, like we just talked about.
Yeah.
So the only kind of patent that would then be available to a lowly clinician would be a use patent. And so there have been some use patents, like for migraine headaches. But Alistair and I didn't know about patents. Can you believe it? We're scientists, and we did not appreciate the business side. Now that the idea was such a good one that it is the most commonly performed cosmetic procedure in the world.
Yeah.
But in those days, we didn't know that would happen because in those days, everybody thought we were frankly crazy. Why would you use that terrible poison on something so frivolous as a wrinkle? Yeah. First of all, it's not a poison if you know what you're doing with it. And we'd been doing an NIH study. We knew the doses to use. Secondly, is there anything frivolous about a wrinkle?
That's a great quote.
Well, that actually leads me to my next question, because as I understand it, Jean, it took you about 5 years to recruit 17 people who trusted you enough to treat their glabella. So across in New York, you've got Michael messing around with the same stuff in 1991. You were doing it in the hospital setting, I think, in your clinic with the blessing of your various mentors. How did you convince, people to let you inject not just the glabella, but their whole face, including their neck, because you were getting more experimental? So tell us about the difficulty that you had, and maybe a little bit more about your first trial.
Sure. Back in the summer of 91, I should credit Richard Listman, who's an oculoplastic guy, the king of oculoplastics in New York, mentioned this botulism-like stuff that you could inject, and people were using it for strabismus and blepharospasm. And I think about 15 seconds later, I said, what about the glabella, the forehead, and the crow's feet? And maybe 20 seconds later, what about the platysma? And within a minute, what about the DAO? And I was still a fellow, but I was doing a fellowship with the facelift kings of the world. And back then, most people were getting a coronal brow lift. So they had an incision across the top of their head, folded down their forehead, and we would pluck out or checkerboard or bovie or cauterize little segments of different muscles. And believe it or not, my job, when we went into the operating room, right before they went to sleep, I'd say frown. I'd draw in their frown lines, raise your eyebrows. I'd draw their lines and smile, and I'd draw those lines. And as soon as they were asleep, I'd stick methylene blue in there. And so I knew which segments of the muscle were stronger, which were weaker, where we wanted to take away little bits of muscle. So I was in this hospital, which is the mecca for facelift and facial rejuvenation surgery, and I was their fellow. So it made it a bit easier for me to recruit patients. Patients always came in complaining of these things. And I said, there's something that's approved, not approved for what we're going to do. And I had the blessing of my program director, the department chairman. And since he was retiring that year, the next year's department chairman, just in case there was an issue with this going forward. And it's not like today, but it was not quite as difficult. It was like a 15-minute conversation. But most of the people that I started injecting in my fellows clinic started from the first couple of patients that I injected that were wildly happy. And so they would send their friends to me, and I would, of course, go through all the informed consent back in those days, and it was easy. By the end of 91, I'd injected every muscle in the face on purpose, not accidentally. And I wanted to really get a handle on spread before I went to the neck. So I waited until May of 92 to start injecting platysmas, because I wanted to really understand exactly what spread I would get at what reconstitution volume and what volume I was injecting before I went to the neck.
And what year did you and Gene and maybe others start communicating to say, hey, I'm doing this stuff and I've worked out this units for here and so on? And were you ever rivals? Did you ever compete?
I think we've always discussed things at meetings. We've worked together on different projects like DAXI, for example. Sure. I've always seen Michael as somebody who's so brilliant, and I love to learn from you, Michael. I really do. In terms of when did I start discussing my own work, I was discussing it nonstop with Alistair, God bless him, and also with Rick Logau and Andy Blitzer, Nick Lowe. We had a small group of us, and everybody thought we were crazy, but we had great discussions. And one of the meetings we had, it was my job to figure out hyperhidrosis. And we would each have a subject area that we had to research and then go through all of the anatomy, physiology, likely dosages, all that sort of thing. So it was really informative and exciting. We had meetings all over North America, and I learned so much from everybody else. It was really great. The thing about the neck, though, my first understanding of the neck was when Fred Brandt was talking about it at the American Academy, which was, I think, early 90s, Michael. Does that ring a bell?
Yeah, somewhere around there. I think it was probably around 93, 94 when Fred first presented that. Yeah. We had our neck papers. There's a little story behind it. Let's just say they were published in the same journal, even though one paper was submitted significantly before the other.
Brandt and Bellman. Yeah. Michael, you know what Fred said in that paper. He was injecting 200 units all in the neck, and he had videos that he showed of more or less instantaneous elevation of the neck and jawline, which I could not believe. So we came back to Vancouver after that Academy meeting, and I handed Alistair one vial with 100 units in it, and I said, inject my neck. So he did. And for 6 weeks, I could not swallow water. And I could not lift my head out of the sink at the hairdresser or do my crunches. And that was 100 units. That was where it occurred to me that if you're going to inject the neck, leave the anterior part of the neck alone, because the muscles of deglutition are right under there. And that's what you don't want to do to somebody. And if you look at the injection sites, because last October, the 26th, I think, platysma was approved by the FDA, and all the injection sites are lateral for a very good reason.
Yeah. It's wild, isn't it? Because I think people take for granted these protocols that are just there for them when they start learning these treatments and products. And I don't think there's an understanding or maybe a full appreciation for the amount of work that went on behind the scenes and the mistakes that were made. So I guess to further that question to you, Michael, what other sort of wild complications did you have? You said that you at one point had treated all the muscles in the face. So what were some of the craziest things that you saw, and how did that sort of guide the way that you modified your technique?
I've been fortunate. Even though it sounds like I did things quickly, in my mind, I didn't. I looked at people and I was very careful. The complications I had, the ones that I remember, were not severe. They were just cosmetic complications. A little brow ptosis, like a lot of people. In 1991, I started out, first patient I injected, I put 35 units in their forehead, which was a lot, right? And so I'm dropping brows. But I learned relatively quickly. I became a relatively low dose forehead person probably by 93. And it seemed back then that I was a little out of step with people, but I think that actually changed and turned around a little bit. And I would also add that we were just talking about Fred. Freddie was one of my best friends. We were more than colleagues. We were very close. And I would say probably the single thing in the world I disagreed with Fred the most about was Toxin in the neck. I know that sounds silly, but he was a high dose person, and my median neck dose was never more than 20 or 25 units. In a rare case, I would put in 30, because when you look at the platysma, it does a couple of things, right? It pulls down the corners of your mouth, helps to pull down your lower face. Those are things we would like to stop, but it also provides tremendous support for the deep structures of the neck, the deep fat, the submandibular glands, lingual artery nerve. There's a bunch of stuff under that platysma that it supports. When you do a facelift, half of a face and neck lift, half of what you're doing is manipulating the position of the platysma. And I like to tack it up to the mastoid, right into the periosteum on the sides, to change and lift the contour of the neck. And I was convinced that high dose neck injections, maybe it might look okay early on. I think in the long run, serves people poorly. I think it decreases support for the deep structures in the neck, and I think their neck ages prematurely. Whereas if you primarily get the bands, if you were to look at someone in a profile view, when the bands pop, they stretch the skin out, right? They bowstring the skin from the chin to the sternum and clavicle, which is not good. And they pull down on the lower face. If you could just relax those parts, but leave the flat parts that don't really yank down for support, I think that is the best way to do the neck. I thought that then, and I think that 35 years later. And I think I have a cohort of patients that are still with me from 1991 that I've been injecting their DAOs first and then their platysma. And if you keep those muscles quiet for 35 years, they don't age like their peers. They don't age like their contemporaries. They just don't. A lot of the bad things that we see with aging down around the mandible just don't happen without that constant downward pull of those two muscle groups.
Yeah, I completely agree. I think traditionally people were treating the bands, but not thinking about what platysma actually does. And I completely agree with you. I think if you stay on the upper half and around the jawline, just soften the bands at the top, that's probably the best treatment. You don't need 100 units. It's just not necessary. Have either of you ever played with botulinum toxin B to any extent? And I'm sure you've used it once or twice, but I guess my question is, why haven't we explored it more? Every new toxin that comes out that I can think of is a toxin type A. So we'll start with Jean. What's your experience with type B?
We were privileged to do the studies for Solstice Neurosciences on B for cosmetic use. And it was so painful for those patients, exquisite agony. I remember one gentleman who was stoic, who burst into tears. It was really quite painful. So it's a lot of pain for short-term-ish gain. It doesn't last as long as A. It lasts longer than E, for example. But I think it's the pH that you have to have. I think it's a pH 5 in order for it to be maximally active. And that's the problem, that the pH is the acidity is what makes it so painful. So I had a lot of experience with it, and we were just getting to an interesting stage in the studies when Solstice decided not to follow through with further cosmetic. It is still approved in the United States and Canada for dystonia and for, I think, sialorrhea, but it's not really found its place in the cosmetic world yet.
What do you think, Michael? Have we missed a trick?
A tiny bit, but not really. I agree with everything Jeannie just said. When B was approved, the Plastic Surgery Society had this traveling teaching course, this Tox teaching course that was funded by industry. And as soon as B was approved, they came to me and said, listen, we want to fold this into our teaching program, and you're going to get some samples, and we want you to inject 100 or so patients with B. And next office day I had, there was a large wooden pallet with shrink wrap plastic around more B vials than I could use in 5 lifetimes. It was just ridiculous. And of course, B was a liquid tox. We've got a liquid tox coming, and people think that's very unique and it's so new. No, B was liquid from way back, which is why you can't mess with its acidity. As Jeannie said, the pH was somewhere between 5 and 6. It hurt a lot. The other thing I would say is that its spread characteristics were a little uncontrollable. It clearly spread more certainly than at the reconstitution volume I used with the other product available at the time. And the big thing, as Jeannie said, is the duration. I would say it's about 2/3 the duration of most A formulations that you have. But the pain, and for me, the spread, I really didn't like, because I did a lot of lower face tox early on. I still do a lot of lower face tox. I always push the lower face. I think it's a wildly undertreated area. But B does have the early onset. So I carried a vial of B in my office for at least 15 years after it came out, because people didn't know. People weren't trained. They would hear about, and we'll mention a brand name, Botox, the first day that was approved. And people would call up and they wanted some Botox on Friday afternoon because their daughter's getting married on Saturday, right? Mm-hmm. Well, everyone's educated that it takes a while for it to work. But back then, lay people had no idea, right? So I would always get some Botox emergency come in. And so that I had something to treat these people with, I kept the vial B in my office at all times. And I told them that it would hurt, and I told them it wouldn't last as long, and I told them that it had a little spread issue, but whatever I was doing, I felt confident doing. Everything, first of all, everything I've injected in myself first. And I did not have swallowing problems, but when I did my first B injection and I used relatively low units in my platysma, I sounded a little like Rod Stewart for 6 weeks. I got one of my vocal cords, and I had this weird sort of raspy voice. Good thing I didn't get both vocal cords.
Yeah.
Yes. That would have been, I guess that is my biggest complication.
On yourself?
One of my vocal cords, on myself with B. Yeah.
So one of the most controversial areas of discussion in the industry at large is the way that new people coming into the industry, whether they be doctors or nurses, in terms of how they're trained. And we've got wildly different approaches. A lot of people trying to teach new injectors how to do things in a few weeks, a couple of days. I think most of us that are sensible agree that we haven't really got a standardized program that we think is sensible and setting people up the right way. This is a question for both of you, but I'm going to start with Jean first. How do you approach, or how would you approach training a new injector from scratch in terms of taking them on that pathway from things like anatomy? Do you start with tox? How long until you might introduce fillers? I'd just like to get an understanding of, both of you are at the top of the game. So how would you approach this?
But I think to answer that question, which is an excellent one, thank you. I think you have to ask yourself, what is it that the patient needs from their treating person, no matter what their primary degrees or background? And if I'm the patient, I need whoever's injecting me to understand what I want. That's number one, because it's the aesthetic world. It's not what I need, it's what I want. And the second thing is, can that person analyze my face using their knowledge of anatomy and using their knowledge of physiology to give me the result that I've asked for? And have they ever done it before? And it comes down to such simple things as, particularly when we're talking about something like fillers, as the germ theory, quote unquote, theory. We need sterility, and we need, Michael and I are both surgeons. Sterility is second nature to us, and knowledge of anatomy and physiology is second nature to us. So I think that when people start out thinking, oh, I can just take a course on the weekend, and here's my piece of paper, will you just draw where you inject? It's not so simple, because you have to analyze each specific patient in a predictable sort of way, and you have to persuade the patient that what you're going to do is going to give them what they want. So I think that there have to be, I know in Europe and I think it's in Poland, I think they have a course that you take in order to become an official injector. But I know in England, I think there are people who are certainly not even medical. Is that not true?
Yes.
Who are injecting, that sort of thing. And we've all heard of hairdressers injecting, well, I've got this really great bottle of olive oil I can inject as a filler. It's just the medicalization is really so important.
Yeah, what do you think, Michael? Would you add to that?
I agree with what Jeannie was saying. I would start high concept. In other words, you're looking at a patient in normal animation, they're talking about something, and you just watch their face move, and you think, what areas would look better if we relaxed them a little bit, or they weren't contracting so strongly? And typically it's the forehead. You watch the forehead lines and the crow's feet lines, but I'm obsessed with people's DAOs and their mentalis and their orbicularis oris as well. And then you decide, how much weaker would you like to make them? Is it 20%? Is it 50%? The glabella, is it 98% or 95%? And then you go about thinking about how much muscle mass is there. And then you get the dose. And then you pull up the dose. And then the next step is, how do you apportion that dose in that muscle or that muscle segment that you want to weaken? And I think that's the best way to teach anyone, regardless of their background. Now, what's the problem? The problem is that would be all considered off-label. And so the companies are forbidden from teaching that to people, right? The companies have to stick to strictly on-label injection patterns and doses, and they're all standardized patterns. And I've said this from the podium 1,000 times, standardized patterns and standardized doses will be great as soon as we start making standardized people, right? But that's not happening anytime soon. And so the FDA, when they look at things, they created some draft guidelines that I didn't agree with, and I wrote them a long, not very nice letter, and then I had to go talk to them. They demanded that for upper face tox, but it certainly seems to be holding true now for the lower face, that they wanted a 2-point composite endpoint on a 4-point scale. So if you're a 3 or a 4, if you're 3, you got to go to 1, which is basically no motion. If you're 4, relatively strong, you've got to come up to 2, or you can transpose everything by 1 if you want to have your scale from 0 to 3. And for both the patient and the doc to think that they've moved at a minimum of 2 points on a 4-point scale means that they're tremendously weakened. That is, maybe it's okay for the corrugators, where we tend to weaken people fairly strongly, not all the way, not all the time, but usually. But for the other areas in the upper face, I don't want my patients' foreheads moving less than half of what they did or their crow's feet on a 4-point scale. I think that leads to them looking weird. So that is a problem. If you're a new person starting out and you don't want to pay money to go to a course, all the companies now have their institutes or their learning annex, and they all have very important sounding names, and they do spend a lot of money and they do try really hard. But I always think of that movie, Thank You for Smoking, and the American Tobacco Institute, who would come up with these ridiculous studies and ways to do things, because they have to teach exactly on label to people, which, in my opinion, is clearly not the best way to treat people. It's the best way to prove that a drug works in that muscle group. It's the best way to compare numbers when the FDA is deciding whether to approve a drug for a certain area or not. That it's really good for. That makes sense. But then they're limited to teaching it that way, which makes almost no sense to me. And it's overly standardized, and I think heavy-handed. The 2-point composite endpoint is a nice endpoint to differentiate between toxins and to see what's going on in an area. That does not mean that it's a good way to treat actual people.
I completely agree. There's any number of famous people who are wooden. Their faces do not move. There's a delicacy to the face.
Yeah.
There's a refinement and an elegance to the face, and it can be improved on. But I think completely denervating the face takes away what's going on in their frontal lobe. Nobody can relate to them.
Yeah. So what I'm hearing from both of you, and correct me if I'm wrong, is that the two most important skill sets that you would want to impart on a new injector would be the consultation process, as you said, to understand what the patient needs, even what you were saying, Michael, even not actually the words that are coming out of their mouth, but part of that consultation process is observation, making your clinical assessment as you're interacting with that patient, and understanding anatomy. And to me, when I look at most of the training that's done, and I'm a layperson, so I'm saying this just with observing and being involved in the space for 20 years, is that people rush to technical application of technique. And we now got the commercialization with a lot of chain clinics, and they're trying to pump out injectors really fast to keep up with demand. And they're sending people on these turbocharged courses, and everyone, they're learning toxin and filler and off-label and cannula and all this kind of stuff. And what both of you are saying is that before you even think about putting a needle in the hand, is understand how to consult and actually understand the anatomy of what it is that you're planning to treat. Would that be correct, Jean and Michael?
Yeah, I think so. I've come to that realization so much that now I don't do any consulting unless I'm standing in front of my Canfield IntelliStudio, because I used to hand people a mirror and I never knew what they were looking at. I thought I knew, but this way I know, because we're both looking at the same pictures at the same time, and we can scroll back and compare the pictures on 2 separate dates. And so then you also can cover one side of the face or the other part of the face and say, what do you think? It gives them an input. That's really important. When you're doing a consult, if you're just telling them what to do, you're going to have an unhappy patient. But if you can actually draw them into the conversation and get their ideas, ask them questions, now they're involved and they love it, because most people don't give them enough airtime. So I think it's really important to add that into the mix as well in the consultation process, to allow them to express what you've been saying, to discuss the pros and cons of that as well.
Yeah. Did you want to add to that, Michael?
Yep, I agree with those 2 points completely, but I would also add a third point. And the thing is, to get really good or even reasonably good, you must see all the people you inject back in a timetable where the stuff is working. When I first started out, I kept strict stats on this. The first 1,000 patients I injected, I somehow talked 810 of them to come back in 3 or 4 weeks so I could see what was happening. If you don't do that, if you rush into some training, which is not really a high concept training, but it's 1, 2, 3, 4, 5, 1, 2, 3, 4, 5, 1, 2, 3, something like that. There's not a lot of thinking. You get a job in a clinic where you've got to churn patients, and you would be disincentivized from bringing everyone back and staring at them for 20 minutes and asking them to go through different animations and things. Yet that is the only way you'll ever get really good at it. The first two steps are necessary and they're important, but unless you get some feedback, you'll never be really good, because I'm going to say something that sounds a little weird, and that is units are not translatable between injectors, because where I might stick the needle 8 or 10 times in somebody's forehead with different aliquots is going to be different from where someone else looking for motion in their forehead would stick it. And so this sort of obsession with just dose, I think, is an error. I think that it differs between injectors. It certainly differs where you put the needle. You bring in 100 foreheads and have 5 different experts inject them. I guarantee you those needles are going to be going to different spots, and the aliquots will be of different sizes. So how is there going to be one dose that works for everybody? How's there going to be one dose, a unit dose that's the on-label dose that is the best dose for every human being alive who comes into the office? Obviously, when you say it like that, it's obvious how ridiculous it is. However, that is how the majority of people in the world are trained, because they're trained by the companies, and the companies realize this, but they are forced to do it that way by regulation. And it's a shame, because it's doing people a disservice.
Yeah. And I guess you got injectors not knowing what they don't know. As you said, Michael, how on earth are you supposed to get better at something unless you can see the results? And if you think about all the different faces, the age groups, the ethnicities, what people think they want their face to look like, there's so many possible variations. You'd have to see so many faces to be able to build up an internal catalog of how you would approach certain scenarios. And how can you do that unless it's like you're flying blind without a map? How do you know where you're going?
100%. And nobody is perfectly symmetric. If you were to just go through my charts from today, and probably the most patients I inject, I'm an area injector, so the number one is 5 areas. I guarantee you that none of the patients that I injected were symmetric. Now, if I'm not injecting their left and right faces the same way, how is it that every person in the world should have their face injected the same way?
Yeah. And I'm assuming that
doesn't make any sense.
And I'm assuming you're also refining your technique over time. So each time you see that patient, you're going, they might be seemingly happy with the result. With your expert eye and your expert eye gene as well, you're looking at that face going, you know what, I can make that better next time.
The other thing is when you see them back, and I completely agree with Michael's third point, when you do see them back, it's good to have photographs so you can compare them before and after. And seeing is believing. They're just so happy with that. Likewise, when they come back and they say, it didn't work. And so come straight in and we photograph you, and then we do the compare function, and they,
yeah.
Because people can't remember what they looked like a week ago, but they didn't realize it was a change until they saw the before picture.
Yeah, you're so right, Gene. And I think we've banged on the podcast so many times about clinical photography. I think people thought that we're obsessed with this, but it's the only way of grounding patients, because one of our previous guests said all patients have a disease and it's called amnesia. They just don't remember. So I think it's a really important point.
The counter argument to that is I'm busy. If I see a whole day reviewing patients, that's time I'm not making money, etc. And I just want, from a business perspective, because that's my area of expertise, is business and understanding how clinics work and how to get them to make money, is that if you look at it from the other perspective, which is if you're getting great results for your patients and you're continuing to get their results better, that's going to increase your retention. It's going to allow you to be more elastic with your price. People come to an injector based on value to a point. And so if you're getting a result they're not getting anywhere else, then your retention will increase. How much you can put your prices up will be determined on how that perceived value is seen by that patient. And when you think about the competitive landscape that we're in now, if you've got that edge over your competitors, your patients aren't going anywhere else because you're getting them results that no one else could achieve. And you've got that elasticity to increase your prices when things get difficult or your competitors are struggling. It far outweighs the money that you'd make from not being able to see new patients on the day that you're reviewing. So just from a business perspective, in the long term, the long play is that makes more sense. And I'll shut up there and let you carry on.
I think it's a very valid point. I'm going to ask you a question beyond Wrinkles, Jean, because I think you said in your first podcast with us, you said the first lady you treated, I think she was your receptionist, and she said, I love the fact that the wrinkles are gone, but I also have this beautiful untroubled expression, or I think that's the words that you used. So you've since done work on how onlookers look at patients and how their expression changes how they're perceived, but also patients also feel negative expressions or negative feelings differently. So depression is potentially improved because they can't manifest the expression of anger and depression. So can you just tell us about that work? Because I think it's fascinating and I think it's probably overlooked. You've still got Injectors worrying about wrinkles, where it's far more than that, really.
It's a lot more than that. It actually happens. The mood improvement is something that is cast iron in, I think it's over 20 prospective randomized trials. It's been looked at, but the SSRIs are relatively effective in about 40 to 50% of people, and they've been around for longer. And I think also psychiatrists don't traditionally inject. So there's a couple of little wrinkles there in the delivery. But to put it in the untroubled, the lack of anxiety, the improvement in social performance, the improvement in mood is there. That's one of the reasons they keep coming back. Yeah. And it's one of the reasons that when I get them to frown, if I see the omega sign, which Charles Darwin noticed in 1862, I think it was, I know that there's depression behind that. But in order to get this to be something that's approved, there have to be trials done and a formulation that is long enough lasting. But I think it's what you've hit on is the future, because I see that emotional wellness is going to be a huge new part of the use of neuromodulators.
Yeah, I've also seen this criticized where influencers that aren't necessarily doctors or injectors, they say, see, freezing people's faces is terrible because it makes those people apathetic and emotionless and so on. I don't know if you've got any evidence to counter that, but some of the non-Botox supporters will say that there's a negative to some of this.
You hear it all the time. And the thing is that we're talking about women here mainly. And we age earlier than you men do. We start around age 24, 25, getting remodeling of our facial bones, which doesn't come home to you until mid-40s. So we're already dealing with our brows coming down and our jaws shrinking. To Michael's point, the lower face is a very essential, as well as popular, treatment location. And so the point about the treatment with neuromodulators is really that we're allowing people to express themselves more accurately rather than not at all. How can you express contentment if your brows are down and they're knitted together because you're a focused person? And we have teachers that come in and say, kill it, because the kids are scared of me. They think I'm angry. Or I have judges that come in and say, don't kill it. I have to be able to frown a bit when I sentence them. There's all kinds of nuances to this, but the basic thing is, I think you can, if you listen to your patient and you know how they live and what they do, you can actually give them the perfect response, post-treatment response. I think that's something that it becomes something that you really look forward to with your clinical practice, is being able to give people a nuanced approach to what they need.
Yeah, I think it's so obvious. The patient satisfaction is so high from your very first patient through to what we're still doing now, 30 years later.
Yeah.
Even if we can't quite quantify it yet, I think it's very obvious the effect that the treatments that we're doing has a very positive effect. But yeah, it's easy to critique if you don't understand it and you just think about frozen faces all the time, which is not what we're aiming for.
Yeah.
To your point, there are a lot of really frozen faces out there. Yeah. And that's maybe from people not understanding that there's a way to do this rather than that way.
Yeah, absolutely. Hey guys, I hope you enjoyed part 1. Part 2 is available right now. It's free and available, but you must join our Patreon as a free member. All of the information on how to join our Patreon as a free member is in the podcast description. We'll see you in the next podcast, guys. For our latest news, follow us on Instagram at Inside Aesthetics Podcast. If you want to get in touch with myself or David, follow us on Instagram as well at Dr. Jake Sloan and David_Inside Aesthetics.
Join our Patreon for invaluable business and injectable education. Get access to our global community of like-minded professionals, live and interactive Zoom sessions, hints and tip videos, webinars, and more. Head over to www.insideaesthetics.com/Patreon for more information.